And the reason for that, and those of you who work with the patients in this situation know very well, what a person says and how they feel at the moment they're coming out of the hospital is not necessarily where they will be in 2 or 3 weeks, right? So we want to get ahead of that decision a person might make a few weeks down the line, even if they leave the hospital with the best of intentions. At some point we know from their past behavior, and again, you have to show the pattern of behavior to even qualify for this under the law. But we're talking about people who start to tell themselves when they're doing well, I'm doing so well, maybe I really don't need these meds, and they go off track. We want to get in front of that before it happens. We don't want to wait till a person is in a crisis before we start them on AOT. In fact, the ideal time is when we can make that soft landing right from the hospital, upon hospital discharge, and get the person off on the right foot. So we want to have this court order in place and this is the case for most of the people who will go under AOT. It's not kicking and screaming and this is the worst thing that's ever happened to me. Most people you will find when you have your own AOT programs actually do embrace this and are all for it at the point in which they get started under it. And so because of that, you don't necessarily have to have an adversarial hearing, right, where the person is contesting the AOT order. You can do this through a voluntary settlement agreement. You can have the person, and this is what's going to happen in the majority of cases, the person sees AOT as their ticket out at the hospital. They're being told, we can release you if you're willing to take part in this program. And so they're all too happy to sign up to be part of it voluntarily. But one thing I feel is best practice when you sign voluntary settlement agreements with people coming into the program is to still bring them before the judge, to have the judge approve that voluntary settlement agreement. And just as you would for someone who is contesting the court order and going under a formal order, you want to have periodic status conferences with the judge during the period that the person is in the program. Still have that person feel that sense of obligation to a judge, that there are expectations of the court that they take part in this. So the normal thing we do as lawyers, where we kind of don't bother the judge when we're able to voluntarily settle a case, it would be a real shame to apply that here because we'd be kind of missing out on the black robe effect, which I kind of call the secret sauce to AOT. So we have lots of data. I want to kind of wrap up, leave plenty of time for you guys to ask questions, but I do want to quickly mention that we have lots of studies. This concept has become much less controversial in recent years than it was before as our kind of mountain of data has piled up. Much of it, I think the most robust studies come from my home state of New York, where our law that I mentioned, Kendra's law, came with a requirement that the law be studied. We actually put a sunset on it, right? We said that this law will expire in 5 years. That was extended another 5 years with these studies attached so that the legislature could make a decision as to whether this was actually working and whether some of the opponents of this were right and that this was having some negative consequences. And this New York data, as well as some other studies that we have around the country, have really shown that the impacts are tremendous for this really difficult to serve population. Again, we're not eliminating hospitalization for these folks. We're not eliminating arrests, but we are slicing these negative outcomes in ways that really no other intervention, I think, can touch when you're talking about this very challenging population. So you see in New York, likelihood of hospital admission over 6 months cut in half. The number of days people spend in the hospital when they do get hospitalized substantially reduced because we're getting people in at a point where they're a lot less ill. Likelihood of arrest being cut in half. Huge reductions in the likelihood of people to commit serious violent acts. Some of the parade of horribles that we were told might happen in New York were actually completely discredited by the study. There was lots of worry that this was going to lead to a destruction of the bonds between caregiver and patient because people would feel coerced and stigmatized by the idea of having been placed in this program, and that that would cause folks with mental illness to go underground because they wanted to kind of avoid this scarlet letter of AOT. That actually was found not to be the case at all. People under AOT were compared to other people in the public mental health system and reported no greater sense of stigma, no greater sense of coercion, which isn't to say some of them didn't feel that way. Some did, but a lot of people in the public mental health system who were not under AOT had those feelings too. And what turned out to be the great predictor of whether someone was going to feel stigma, feel coercion, was not whether they were under AOT, it was, surprise, surprise, whether they felt they were treated with respect and dignity and compassion by the people they interacted with who represented the public mental health system. And there is nothing in this AOT model that should ever interfere, and I think the videos you saw already really makes clear. This is in no way inconsistent with treating people with respect and compassion at every turn, and engaging them and involving them in their own recovery, and allowing them to participate in the development of this treatment plan to the extent you can is always a great thing and should never be discounted in AOT. Another kind of really important finding I want to flag here is that AOT was found to save public mental health systems a lot of money. So if you live in a place where you're being told we can't do this because we can't afford it, I can help you go back to those same folks to make the argument that in fact, if your system is financially strapped, that's all the more reason why you've got to do this, because this core group of super utilizers is absolutely eating the lunch of our public mental health system, because we're hospitalizing these people again and again. And here you see, although we have some increases, right, in some of the spending up front, there's no question there's some upfront investment that has to happen for AOT to work. Although we're spending some more on medical treatment, spending some more here on the legal process involved. We're looking at huge reductions in spending. This is hospitalization costs for New York State, hospitalization covered by Medicaid. You see comparing, this I should say is comparing people in the 12 months before they went under AOT to their first 12 months after the order, and then looking at the year after that, by which point a lot of people are graduated from the program, some remain on it under a renewal. But you see these unbelievable reductions in the dollars being spent on hospitalizing people, which just dwarf modest increases in spending on good care up front. So, from my point of view, this is just a no-brainer. And, I'm happy to say that these guys here in Lake County, Florida are finding some of the same results. We have some preliminary data that's coming to the surface now because they're part of this SAMHSA grant program and a cross-site evaluation where we are going to hopefully study how well this is working in all our grant sites and make a pitch to Congress based on that data to have a much greater federal investment in getting these programs off the ground. And so from the initial data we're seeing already here in live streams programs, huge reductions in the number of days people are spending in the hospital, huge reductions in days people spend incarcerated, and in the client interviews that they are doing both before and after people enter the program, where they're asking patients to just make subjective reports on their condition, various subjective factors like social functioning or avoiding distress. People who are participating in this program are reporting that they feel much better, that they feel they are doing much better than they had done before. And again, you saw that for yourself in the video. As Karen mentioned, this can be done without a SAMHSA grant. I would hate for anyone to take from this that Lake County can have this, but you can't because they got a SAMHSA grant and you didn't. We have lots of communities around the country who have found ways to make this work. It's just a little bit of upfront investment with the understanding that it's going to save lots of money, not just for the public mental health system, but also for the courts, right? There are court resources. We have to invest in this, but if it's going to allow us to avoid holding inpatient hearings, right, having to hospitalize people again and again, that's a whole lot of savings of the court's time and resources as well. So this collaboration that it takes to make this work between the court system and the public mental health system is something that we at Treatment Advocacy Center have helped make happen in lots of communities around the country. And I have some cards today, and we'd love to work with any of you to make it happen where you live. We want to make Florida one of the states that has this more as the rule than the exception. So I appreciate you all listening to me, and have some time left for questions.